Nomathemba Chandiwana, who is a clinician scientist from South Africa. She's one of the PIs of the advanced trial, and I think she made some presentations earlier today, which are very interesting. She also has some investigations on accessibility to therapeutics for COVID-19 patients. So she's going to speak on HIV prevention, how to make it happen in Africa. So you're welcome, Nomathemba.
Thank you very much. I would like to thank everyone in this room. You know, the pressure to be the last person to present on a long day, which has been very interesting. So I'm going to keep it short and sweet. A lot of things have been said by my colleagues, and I'll just take a different angle of how to scale up prevention and how to, in the African context. These are my disclosures. So the objectives are really to focus on the challenges of rollout of HIV prevention and how to overcome some of these barriers. So this is something that we've all seen. You know, if you think about it, in any clinic, probably a decade or two ago, we were seeing this, where people were telling us the ABCs. So the ABCs, since the pandemic, were initially abstinence, be faithful, condomize, counseling, and then later on there was circumcision. So in the context of the African continent, when we didn't have options, ABC seemed like it was something that was feasible. But as we all know, there are definitely a lot of limitations. But in a country like Uganda, we were able to reduce infections quite drastically because of these. However, ABCs failed to look at other key populations. For example, women who were not able to negotiate condom use, other populations such as men who have sex with men, where ABC might not apply to them, and also things around, it also failed to address other issues as well. But it's quite interesting how far we've come as now we have so much more in our toolbox. So in our toolbox at the moment, I'm not going to go into it, it's been said in quite a lot of detail. But PrEP, PEP, we've got so many things in our toolbox, from oral PrEP to injectables to other long-acting formulations that are available. And this has evolved, and it's quite an exciting space from what we had not only 5 years ago, and also what's coming is also quite exciting as well. So despite these gains that we've had with the range of technologies and efficacy of these technologies, this has led to an optimism of saying that we'll end AIDS by 2030. We were 2020, that didn't happen. But one thing I love about our community is that we never give up. We always set ourselves targets, and targets, I know they may seem aspirational, but they are important, and they're a good way of charting our progress. So by 2030, we are hoping to have less than 200,000 infections by that year. But progress has been slow to reach these targets, with over 2 million infections that have happened in 2020. So HIV prevention in particular lags in Africa. This has been spoken about a lot today. Women and young girls in particular fuel the pandemic in East and Southern Africa. Countries such as South Africa, Swaziland, Lesotho, Malawi, we have such high levels. So though we've had encouraging trends, let us not mask the fact that certain populations, particularly women and young girls, still have unacceptable high rates of HIV infection, which means our prevention efforts are not reaching the people that need them the most. So, and also despite all the things, the strides that we've made, PMTCT in particular has been amazing. From having 20 to 30% infection rates 2 decades ago, we're going to 1 to 2% in most of our settings. And despite all these advances that we've made, AIDS-related deaths still occur mostly in sub-Saharan Africa. So the vulnerability of young women and girls has been highlighted several times today. But while the uptake of prevention modalities has been high in certain groups, particularly men who have sex with men in high-income countries, that has not translated to our settings in Africa, where we still have less uptake. Only globally, 25% of people who need PrEP are using it. And this is mostly in high-income countries. And in African countries, the numbers that we have are way, way less than that. So we've got disappointing levels of uptake of adherence. The challenges of oral PrEP have been spoken about in the previous presentation, that we need to make things that work better for people, especially the ones that need them. And also lessons that we've learned from other populations. How can we extrapolate that to our own setting? Demand creation. I think as we have started a lot of things, we've medicalized prevention strategies. They exist within clinics and hospitals that have got multiple barriers for people to reach. So how can we have different models of care that was spoken about, pharmacies, doing things in the community in particular? So because prevention is not, the perceived risk that a person might have is different from a person who's looking for treatment. So the barriers for HIV prevention are quite a lot. So I've just highlighted a big one. Stigma is still a big one, for people to take a pill, which is an antiretroviral, for a disease that they do not have, is a stigma. Because if you see someone taking PrEP as a pill, you don't know if it's for treatment or not. So people often feel like they need to hide. So other modalities are important, things that are discreet, things that work for certain populations, the long-acting injectables, the vaginal ring that was spoken about, and other PrEP characteristics. Some people have complained about the smell, the taste. I find that in the treatment community that patients are long-suffering. Because they need it, they often don't complain. It's when you change a regimen that a patient would say, I've not been doing well on efavirenz. I've been having all these things, when they've changed to a dolutegravir-based regimen, for example. But with PrEP, people would highlight the things that don't work for them. So poor community engagement. You'll find that in a lot of settings that PrEP options or prevention options are not, again, in the clinic setting, or we don't have a community engagement, which we did have, I think, more in the treatment space than we do for prevention. Inadequate funding, medicine stockouts. This is a big thing for healthcare providers. So as the community is really excited about long-acting injectable PrEP, but healthcare providers are not so excited. We spent years decanting clinics, and now what are we going to do? That's a barrier to scale up of these wonderful and very effective prevention modalities that we have. Accessibility concerns. If you have to go to the clinic all the time, can we do it in different and innovative ways? We've seen this in different parts of the continent. People are using ATMs, people are using peer educators, and also things around gender norms, both for men and women. Toxic masculinity, something that we've heard, real men don't use condoms. That might be true of PrEP. And even sometimes for women, them not feeling that they cannot use certain, and I say norms in quotation marks, because culture moves, it's not static. So there's nothing that can be a norm forever. So now that I've spoken about the barriers, what can we actually do to make sure that PrEP happens in an African context? So facilitating factors include high HIV risk perception. There was a lot of research on this earlier on about if you perceive yourself to be at risk, then you will use prevention modalities. Peer influence. This is a given that if your friends are and your peers, this is not only for young people, but it goes along the range that if you have people in your community using certain modalities, you're more likely to use them too. And also appropriate evidence in efficacy and safety. A lot of trials are first done in high-income countries, mostly among men, white males in particular, but the users and the people who need it the most tend to be African young women. So clinical trials, and this has changed a lot, that we're having clinical trials in the populations that need them. And within this, we get a lot of other information besides the clinical endpoints, things around acceptability, etc. That was done a lot in long-acting trials. And convenient and responsive services. Do we have them available to us? I find it interesting that in this day and age, in the private sector, a woman still needs a script to get contraception. This is something that most women are using most of their lives, but you still have to go see a doctor, pay an amount, which is ridiculous given the fact that women are on contraception for 2 or 3 decades of their life. Same goes for PrEP. How can we combine them? How can we integrate our services? And also the social support that we need. Reducing cost. There's been some criticism of some drugs that are coming up, and also the big thing of including key populations as well. So this is a model that I found quite interesting. It was developed through a consensus discussion. The consensus discussion at the Banbury Center a few years ago. And the outer boxes are looking at key characteristics that input a theory and evidence based on prevention program, which are required to deliver a holistic package. So things around ownership. Do prevention users feel like they own it? Or is it something that they feel like they're not a part of? Evidence, I've spoken about this. Trials and practice. Are they applicable to the environment that we're scaling up prevention modalities? Is it responsive? Do people have choice? I think choice is something that has been echoed in the last 2 presentations. We need not, it's a one-size-fits-all, that time is gone. Different populations need a choice of what works best for them. And is it embedded in the structures and in our communities? And also the integration with STI as well as other sexual and health services. So in summary, again, choice. This is very important. And let's not forget STI prevention. It makes you more susceptible to HIV acquisition, and this is important when we look at prevention as well as screening. And also we're paving the road for HIV prevention for key populations. I think key and vulnerable populations, we often look at the low-hanging fruit, but HIV prevention is hard. I think when we look at treatment as prevention, people are very excited about that, U equals U. So you're putting the prevention on people who are living with HIV. But prevention itself is actually difficult. This is why we are here 4 decades later. And combination prevention options. There have been some exciting things that were shown in the previous presentation around things that will prevent STIs, pregnancies, and HIV. Vaccine trials have not done so well. There's recently a vaccine trials in Bogoto was stopped early because of efficacy issues. So we have to do a different approach. And COVID vaccines have actually, I think, stretched what we can do for HIV vaccines. And also, this is a call to action for all of us in this room. We should refuse that HIV acquisition is the norm in Southern and East Africa. We say it all the time, young women and girls, we've got taglines that we use. But I think with all the progress that we've made, we also should refuse the status quo around certain populations, and also accelerate access to multi-purpose technologies. So I'd like to thank my colleagues that helped me with this presentation and for their inputs. And that is all for today. We'll hand over to the chair.